Okay, so these are my disclosures. So if we look at the incidence of colon cancer, and this is from the incidence report from Saudi Arabia in 2016. Colorectal cancer is actually the commonest cancer in men, uh, um, uh, with about 16.5%, and it's the third in women, about 9.6%. So it's something that we see very commonly in our center. About 80% of our patients that are either colon cancer or breast cancer. Um, Collectively, it's the second after breast among all the Saudi nationals by about 12.6%. And it's again, it's the commonest in men and the third in women. Adenocarcinoma by far is the commonest histopathology. It's all adenocarcinoma, however, with some features like mucinous or signet ring cells. About 1/3 of patients will present with localized disease. This is across all the men and women, and about another third with distant metastasis, and about 40% with a regional disease, meaning lymph node involvement. When we talk about colon cancer, we're talking about probably two different diseases. So nowadays, and this is the new fancy thing about colon cancer, right versus left, they have a different presentations, they have a different molecular profiling, and they have a different outcome and probably different predictors to the treatment. So if we look at the right side, they usually present late because of the anatomical locations. Common in female, older, they have more BRAF, which is the poor prognostic factors. They have more MSI high and more comorbidities, while in the left, colon cancer, they usually present earlier, again, because of the anatomical position in men and younger, and they usually present with a more acute presentation. They have more or better prognosis. These just to show you that the some of the meta-analysis and a retrospective trials of metastatic colorectal cancer, and how that would really influence the outcome on the primary tumor location. So in 66 studies, the first one here, a huge number of patients, it was treated, found that left side treated with a reduced risk death with a hazard ratio of 0.82. Another meta-analysis with a 13 first-line randomized trial, about more than 6,000 patients. Right side was treated with a worse prognosis. And this is lead to the next section. How does all these data influence our practice? So we know that primary tumor location will impact on the overall survival. If we look at the anti-EGFR or EGFR antibodies, cetuximab or pembrolizumab, in the first line, we look at the PRIME and CRISTAL. One of the these are the landmark studies. They looked at the activities of anti-EGFR. Look at the left side here, 30 months versus 11 months with the addition of panitumumab. Cetuximab 28.7 months. So again, with the left side, more benefit seen with anti-EGFR. This is just a brief and overview. We know that colon cancer, when it metastasizes, except in a very limited situation, when there is oligometastasis in the liver or the lung, it's not curable conditions. And we know that without any treatment, the median survival just range between 6 to 11 months. However, with the new advances, a new treatment, and a favorable primary locations, we're talking about 30 to 36 months median survival. If we say 100 patients will receive first line, there are actually a good number of patients who will receive a second line, and about 70% of patients, and about 40% will go to third line, and just below 20% will go to the fourth line. These patients, when we usually treat them, we would like to maintain their quality of life, delay the progression, and to improve also the survival. And when we recommend any treatment on these lines, we need to look at the evidence carefully. We need to look at the patient's comorbidities, patient's preference, and performance status. These are just some of the landscape PACE treatment options. We know that the most important age is the 5-year or capecitabine, with the addition of oxaliplatin, as well as irinotecan, with a lot of protocols and evidence behind it. And we have the targeted therapies with Avastin, also cetuximab and panitumumab, providing no mutations. And we have also options for later lines, including the tyrosine kinase inhibitor regorafenib, the TAS-102, and also the monoclonal antibodies, immunotherapy. And I'm going to present to you today also first line data that was presented recently in ASCO. And of course, clinical trials is always a valid option. This is again to show you how things really went fast in the last 2 decades. From the 60s, we've got only the 5-fluorouracil. In the late 90s, we got the irinotecan. CAPE is the prodrug of 5-fluorouracil, and then oxali, and we've got in the last 10 years so many approved drugs from 2010 until today. So which chemotherapy we should use? We should use FOLFOX, FOLFIRI, or FOLFOXIRI. So this is one of the landmark studies in the treatment of colon cancer, and basically this phase 3 trials, they looked at the answer: should we start with the FOLFOX or FOLFIRI, and vice versa. And there was no significant difference in the first or second line therapy for response rate or time to progression or overall survival. However, there was an increase with the hepatic resection rates with the FOLFOX, about 21% versus 9%. Let's talk about the first line chemotherapy with either anti-EGFR or anti-VEGF. PRIME, this is one of the landmark studies. They looked at the addition of panitumumab to FOLFOX4 for those with metastatic colorectal cancer in first line treatment. And as you can see, once we have a wild type RAS, benefit is more pronounced. However, when there is a RAS mutant, it's probably a detrimental effect. We should not use it. This is PEAK, another phase 2 trial, looked at the panitumumab versus bevacizumab, and again, with a wild RAS type, progression-free survival was significantly better with the anti-VEGF. However, with the mutation, no difference between the two. This is the this is the overall survival data. Again, hazard ratio with a wild type of 0.62, significantly better, 34 months versus 24 months. While with the this is the updated analysis, actually 41.3 versus 28 months. Crystal, this is another landmark study. They looked at the cetuximab with the addition of FOLFIRI. And as you can see here, with KRAS wild type, progression-free survival was better with the addition of cetuximab. Overall survival, response rate, and if we look at the all RAS type, even the benefits was even better, because we're not talking about only KRAS. There is also NRAS and other and also BRAF. This is the updated survival with the overall survival with the wild type and all RAS wild type. Talking about 28 versus 20 months, almost 8 months difference in survival. FIRE3, this also looked at the first line metastatic colorectal cancer, and it was a comparison between bevacizumab, FOLFIRI, and cetuximab with the FOLFIRI. And when we talk about all RAS wild type, overall survival rate was better with the cetuximab. Survival also, median survival also better, and progression-free survival was the same. FIRE3, this is the overall survival, 33 versus 25 months with RAS wild type if we use cetuximab. CLGB SWAG 80405. This is again another landmark study looked at the addition of cetuximab versus bevacizumab to the chemotherapy. And looking at all RAS wild type, the cetuximab group did better, and the RAS exon 2 only, there was no difference, which tells you that extended RAS testing is something that should be standard of care. Again, this is just to show you the difference between the two with the wild type and all RAS wild type. How about second line anti-EGFR? So EPIC, this is a study looked at the role of giving cetuximab in the second line after progression. This is an open label randomized phase 3. We have a RAS wild type, oxaliplatin, based chemotherapy randomized to irinotecan with cetuximab versus irinotecan. The primary endpoint was overall survival, the secondary progression-free survival, response, safety, and quality of life. Irinotecan with the cetuximab did actually better in terms of the progression-free survival, 5.4 versus 2.6, and also a significant improvement in overall survival. However, in survival, no much difference between the two. This is just to show you the subsequent therapy influenced the median overall survival in the irinotecan arm. And as you can see here, those who received subsequent cetuximab versus no subsequent therapy, a huge difference of 19 versus 3.1 months. How about panitumumab in the second line? Again, same design, looking at the overall survival, progression-free survival. Comparison was panitumumab with FOLFIRI versus FOLFIRI, and there was a significant hazard ratio and a median progression-free survival of 5.9 versus 3.9, and survival was better by 2 months with a hazard ratio of 0.85. How about the anti-VEGF as second line? So we know, all of us know the TML. TML is the landmark study that looked at the giving bevacizumab in the first line, and upon progression, continuing the bevacizumab, changing the chemotherapy, and that was positive. There is a new data looked at the ramucirumab with FOLFIRI versus placebo and FOLFIRI in patients who actually treated with metastatic colorectal cancer and had a progressive disease after bevacizumab. Baseline characteristics were equal between the two group, and most of the patients had a very good performance status, and 50 had mutant RAS and 50 had the wild type RAS. This is the primary endpoint with the overall survival. It was significantly better when we add ramucirumab to the FOLFIRI regimen versus placebo and FOLFIRI with 13.3 versus 11. Progression-free survival also was better with 5.7 versus 4.5. That resulted in a hazard ratio of 0.79. All subgroup of patients benefited from addition of ramucirumab. And if we look at the BRAF mutant patient, we know that BRAF is a very poor prognostic factors when we talk about colorectal cancer and stage 4. There was a significant improvement in survival, 9 versus 4 months. How about the triplet? Can we use the triplet instead of doublet with either anti-EGFR or anti-VEGF? Macbeth, this is an Italian phase 2 trials, looked at those with the first line treatment who received cetuximab and modified FOLFIRI versus cetuximab. Again, the same randomization, however, after 8 cycles, either to continue with cetuximab or bevacizumab. There was a better outcome with the continuation of cetuximab, and instead of bevacizumab, with a 10-month progression-free survival was 52 versus 44%. Not only that, but also overall response rate was better with the use of cetuximab. How about this is another study also looked at the single arm, 30 patients, looked at giving fulvoxiri with cetuximab, and a very good overall response rate of 70% and a median survival of 30.3 months. Volfi, this is a phase 2 trial, looked at the same, so same idea. Can we give panitumumab with a fulvoxiri versus fulvoxiri? And as you can see here, the super wild type, meaning all RAS wild, the overall response rate was better. And also in BRAF mutation, we've got a significant difference with the use of triplet versus panitumumab. Again, this is a phase 2, a small study.
2 more minutes.
2 more minutes. Okay. So I'm gonna skip then this. We'll go and talk about the recent. So immunotherapy. When there is an MMR deficient, we know that there is a high mutational burden and a very good chance of response to immunotherapy. So this is the pembrolizumab, the cohort that they looked at those patients with MMR deficient, a significant response. This is the progression-free survival, impressive overall survival. I'm gonna skip also Nivo data and go for the new data. So Pembro, this was presented last ASCO, and this is the phase 3 Keynote 177. Basically, MSI high patients, first line, randomized to Pembro versus chemotherapy, with allowing of crossover upon progression. Baseline characteristics were the same. And as you can see, an impressive result. 12 months rate progression-free survival was 55 versus 37, and 24 months 48 versus 19. That resulted in about 16 months versus 8 months only with the chemotherapy. All subgroup benefited apart from the mutant RAS, and the response rate was higher with the pembrolizumab. We know that MSI high, they don't really do well with the response in terms of chemotherapy. And when they respond, they just keep responding. So this is the rate of more than 24 months response duration, 83 versus 35%. I'm gonna skip that. Gonna go and talk about the summary of this. So Pembro did provide a clinically meaningful and a significantly statistically significant improvement in progression-free survival, doubled 60.5 versus 8.1, and an impressive 24 months progression-free survival. How about refractory? So we know that when these patients progress, we've got phase 3 studies that give us more options. So correct study, this is for regorafenib. Regorafenib is a multi-tyrosine kinase inhibitor. This is a refractory colon cancer randomized to either placebo or regorafenib, and there was a significant improvement in overall survival and also progression-free survival. However, the problem with the regorafenib is the toxicities, so we need to be cautious. Also, TAS-102, similar design. There was an improvement in overall survival when compared to placebo with 7.2 versus 5.2, and as you can see, most of the patients will have a drop in the first scan. Not impressive, really, 2 months versus 1.7 in terms of progression-free survival. More options, yes. So HER2 amplifications and RAS wild type. Hercules and My Pathway study, they looked at the addition of the combination of trastuzumab and lapatinib, what resulted in an overall response rate of 30%. Also trastuzumab and pertuzumab, 38%, and there are ongoing studies looking at the HER2. How about BRAF? We know BRAF, they don't really do well, and we know with the TRIBE trial, with the triplet and bevacizumab, the median survival was only 13 months. So can we do better? This is Bacon study looked at the second-line treatment with the addition of penimetinib, encorafenib, and cetuximab versus triplet or doublet versus chemotherapy, and there was an improvement in median overall survival with triplet and doublet, and no difference between the two groups. So this is again another option. So to conclude, colon cancer, we are not dealing with one disease. Colon cancer is probably two different diseases. We see BRAF mutant in stage 4. This is really bad news. However, if we see BRAF mutant in stage 2, this is actually good news because they do better. So many options, so many advances, so many molecular profiling, so many options for our patients. Thank you so much.